Welcome to this short video tutorial on management of a child after initial stabilization following a seizure. In this video, we will focus on avoiding the common pitfalls while managing this scenario. Seizures in children can be quite frightening for families. Fortunately, the initial management of a prolonged seizure is quite well defined as per the APLS protocol. But this is just the beginning of a nerve-wracking journey for parents. Due to lack of uniform guidelines, the scenario is often riddled with pitfalls for the clinicians. These can happen at any stage of management, like arriving at a diagnosis or differential diagnosis, ordering further tests, deciding on treatment, and most importantly, providing adequate information to families. We will briefly look at each of these areas. Diagnosis and differential diagnosis. There is about 30% misdiagnosis rate in epilepsy even in outpatient clinics. This can be due to inadequate history taking, lack of knowledge regarding differential diagnosis, worry about missing diagnosis of epilepsy. Emergency physicians are in a unique position to capture a detailed history when it's fresh in the eyewitness's mind. Let's look at the key elements that need to be explored in history of episodic events that are often missed. One should seek for an open description of the event or review video recordings if available. Specifically, one needs to detail what happened before, during, and after the episode. Document the onset, progression, duration, ending of episode, if the eyes were open or closed, flickering or uprolling, laterality in episode, responsiveness, and any autonomic features like drooling, incontinence, or vomiting. After the event, document the presence or absence of post-event confusion, sleepiness, or any paralysis. In addition, remember to document any red flag features warranting urgent cranial imaging, and in children with known epilepsy, obtain information regarding medications. At this juncture, it's worthwhile remembering the differential diagnosis of epileptic seizures at various age groups. Now, can you go back to the points on history taking and see how you can diagnose these conditions through a good history alone? Investigations. One cannot be too prescriptive about the investigation that need doing for children presenting with seizures. And remember, most investigations can be normal in such children. But as a baseline, if not already done, it will be useful to do a blood sugar level, ECG to assess rhythm, PR interval, and corrected QT interval. Full blood count, urea electrolytes, calcium, magnesium, liver function test, and venous blood gas in under 2s. For known epilepsy patients coming with breakthrough seizures, blood tests are not routinely needed unless warranted by another clinical concern. It will be useful to clarify the role of EEG so that delays in obtaining one does not create undue anxieties for families. Remember, EEG does not confirm or refute the diagnosis of epilepsy. It only forms a part of the entire diagnostic jigsaw. There is a 30% chance of picking up non-specific EEG abnormalities in children without epilepsy. Hence, if there is doubt about the nature of episode in the first place, it's best not to request for an EEG until patient is discussed with or seen by an epilepsy specialist. Also emphasize that the treatment with anti-epileptic medications will be initiated if clinically indicated, irrespective of EEG findings. It's also worthwhile recalling indications for imaging. There are only few indications for urgent cranial imaging in the context of child presenting with seizures. These include persistent focal neurological signs, new focal seizure with signs of raised intracranial pressure or space-occupying lesion, trauma or suspected non-accidental injury, VP shunt in situ, and signs of shunt malfunction. Most well children do not need imaging in the emergency department, and the decision can be made during outpatient consultation in epilepsy clinic. The majority of children with isolated afebrile seizures do not need hospital admission, but there are a few indications for admission, such as infants under a year of age, diagnostic uncertainty, suspected infantile spasms, multiple or poorly controlled seizures, prolonged seizures requiring resuscitation, seizures with an underlying disorder requiring further investigations or treatment, and significant parental anxiety. Do not forget the need for rescue medications in some children. Prescribe buccal midazolam for children presenting with prolonged seizures over 5 minutes. Ensure that these children are linked up to an epilepsy service. NICE Guidelines UK stipulate that children presenting with seizure-like episodes should be seen in epilepsy clinic within 2 weeks. Perhaps the most important part of this clinical encounter will be providing information regarding safety precautions. By and large, such children should not need to restrict their day-to-day activities significantly. Overall, they are advised to avoid circumstances where an episode could have serious consequences. Some examples include riding a bicycle or scooter in traffic, not wearing a helmet, swimming alone, taking bath in a deep bath, etc. Remember to go through actions to be taken during a future episode. Advise parents to video record the episode. For any event lasting for 5 minutes or longer, families should be advised to call a 999 ambulance. In this day and age, it's normal for an anxious parent to seek information from the internet. Hence, it's useful to point them to some reliable websites that provide accurate information. Some useful websites include Epilepsy Action, Epilepsy Society. There is also a free app provided by the Young Epilepsy. This can be obtained from Apple and Google Play Store. Thank you very much for your patience.